Good afternoon, and welcome to the multidisciplinary approach to facial pain treatment. Dr. Zimmerman, Dr. Green, Dr. Patel, Dr. Parker, and Dr. Townsend, thank you for joining us today. I'm Sarah Winter, Marketing, Communications, and Events Manager for the Facial Pain Association. I'm going to let Dr. Zimmerman introduce his team, but first, just a couple of housekeeping items. On the right side of your screen, there is chat and Q&A. So the chat is for conversations between attendees, and then Q&A is where you're going to put your questions. So we'll have a Q&A after the presentation, and we'll try to get to as many questions as we can. Please understand that none of our presenters can answer specific questions about your situation. However, we will ask general questions relevant to most people living with facial pain. Now I'm going to turn it over to Dr. Zimmerman, professor of neurosurgery at Mayo Clinic and a member of the FPA Medical Advisory Board. Dr. Zimmerman, please go ahead.
Thank you very much, Sarah, and welcome and good morning or good afternoon, depending upon where you're from. I think, can they see the slides, the intro slides? Thank you very much. So today for the presentation, what the FPA has asked us to provide from the Mayo Clinic group is a view of a multidisciplinary approach to facial pain treatment. And so instead of one person talking for about 60 minutes or so, we have an assortment of individuals, each who contribute quite a bit to the care of the patient with facial pain. And at Mayo Clinic, we are a large, integrated, multi-specialty group practice. I'll talk a little bit more about that in a second. But of course, being a surgeon, I do have to say that obviously we know for many patients, and not all, surgery is a big part of facial pain treatment and or management. And so for those of you that have seen my videos before, one of the things we talk about is microvascular decompression, taking blood vessels that push on the trigeminal nerve, as you can see here, protecting the small blood vessels that supply the rest of the brainstem, moving them off the trigeminal nerve. And then what actually suspends the brain and blood vessels inside the head are little pieces of arachnoid, or little filaments, or suspension fibers. And if you move them, cut them, tease them away, you can relocate blood vessels off the trigeminal nerve, and you can actually get them to stay away. Now, the reason that that's important is just more than one way to skin a cat. There's no Teflon in this technique. And the reason we talk about that is to bring to the reality what really happens to Teflon over time. And as you can see here, this is the trigeminal nerve here in a patient who has recurrent facial pain. And this is what the Teflon looks like when you're trying to take it out. Usually Teflon is nice and white when it goes in, and some parts of it are white. But then there's discoloration and tissue growth within the Teflon. So there's some inflammation and changes with when you do use Teflon. And you can see again what looks like a Teflon granuloma, this yellow discoloration of the Teflon, and that will be tissue growth. But like as I mentioned earlier, I'm not going to talk a lot about surgery, microvascular decompression. We have many other ways to address the patients that have facial pain needs. Now, at Mayo Clinic, I already mentioned that it's a multidisciplinary and interdisciplinary group practice. And you can see here some of my, if you will, collaborators, partners, and colleagues that are involved in facial pain. And if you meet any of these individuals here at Mayo Clinic, and particularly in Arizona, we can all talk to you about facial pain. We all understand facial pain as it's part of our practice, and we have a large facial pain practice here. And this is multidisciplinary, including multiple neurologists. We have allied health staff, including nursing staff, PAs. We have, you see Dr. Patel from neuroradiology. We have radiation oncology, psychology, and of course, my other partners in neurosurgery. So this is a large group of individuals who each in their own way can contribute to the care of facial pain. I like to call them my facial pain champions, actually. So the last thing I'll talk about before introducing my colleagues is that at Mayo Clinic, I have to say that we have no financial disclosures. I have no financial disclosures with this talk. But important to understand at Mayo Clinic, there is no financial incentive to do any particular procedure or care. We're all on salary. There is no incentive. There is no incentive bonus. So if I ask someone about their options, what they think they might want to choose, if I recommend surgery or they ask about surgery, I don't get any financial incentive. I don't get paid more or less for doing someone's surgery. The same for Dr. Patel for injection, the same for Dr. Townsend for treatment at the rehab the pain rehab center, none of us are incentivized to make a decision that's based on any financial gain. So again, when we talk to patients in our practice, we talk about what is best for the patient, and that's core to the Mayo model of care. Now, again, I was asked to just provide a little bit of an introduction, and I wanted to introduce the team that we've assembled to talk to you today about each individual approach and options and avenues of treating facial pain. Dr. Green is one of our neurologists, one of our headache special neurologists and facial pain special neurologist. Dr. Amit Patel is one of our neuroradiologists and an interventional neuroradiologist, and he'll talk a little bit about some injections for facial pain. My partner, Dr. Parker, is another neurosurgeon who does, in addition to microvascular decompression, focuses on neuromodulation for multiple aspects of neurosurgical problems like facial pain, as well as things like epilepsy. And Dr. Townsend runs our pain rehabilitation center, and she can speak to both some of the options, either inpatient and or outpatient avenues to address facial pain. And then finally, we do have a sponsor booth for Mayo Clinic, and it will be staffed by my colleague, Ms. Maggie Weeks, who's one of our physician assistants who works in the Department of Neurosurgery and works with me closely with our facial pain patients. And she can answer many questions about facial pain, Mayo Clinic, Mayo pain, the approach to facial pain, and the integration of all these caregivers with a patient that may present to Mayo with facial pain. So without further ado, I'd like to introduce Dr. Lane Green. He's a colleague in the Department of Neurology, and he does have a headache interest and a specialty interest in those patients as well as facial pain patients. So thank you very much for being with us today. And Dr. Green, take it away.
Great. Thank you so much, Dr. Zimmerman. It's my distinct pleasure to be here today to talk about this important topic, and echoing your comments about our multidisciplinary approach to treatment of facial pain. Dr. Zimmerman asked if I would talk a little bit about some of the diagnostic approach and considerations, as well as some of the things that are significant challenges from an initial diagnostic perspective. But a lot of our treatments and our care do hinge upon starting with the correct diagnosis. One might think that this could be a particularly easy thing, but over time, what I have found is that it becomes more and more challenging to narrow things down. But it is worth the effort. Really, at the beginning, it really starts with sort of the cores of medical assessments, which relies very heavily on the history and physical exam. And specifically, I've highlighted the history side of this to be slightly larger than the physical exam side, but the two are very important and linked. Many of the diseases and disorders that we encounter in the facial pain realm are still very clinical in their origin. So there's not always a test or a scan or a piece of blood work that is necessarily going to give us the correct answer. And so it still remains on these clinical core aspects. When it comes to the history of someone with facial pain, it really is all about the details, and this takes time to get this eluted. And really, it's that temporal profile, especially the early days of when the pain started, and some of those early experiences can be very helpful in getting to the root cause or the diagnosis, shall we say. Also, things that weigh heavily into it is if someone's had a previous history of headache or face pain. And we also worry about certain pain days, but also what's sometimes happening in the pain-free days, or if they happen to have pain-free moments. But we worry lots about things like frequency, location, radiation, quality, the severity. This is just to give you an idea of the long depth that we go into in trying to elucidate the history, as well as some of the other associated features that will often come along with facial pain are extremely helpful in getting to that diagnosis. Again, not to go over all of these aspects individually, but just to give you an idea of all the different types of things that we're considering when it goes into the history of facial pain. And of course, we always round out the history with sort of a complete medical history, because all of those things are important to the individual in front of us. When it comes to the physical exam, it is largely an extension of that detailed history that came at the beginning. And because some of these things can be manifestations of systemic diseases or disorders. A good general physical exam is important. Of course, there's a lot of extra attention paid to the head, the face, and the neck. And of course, being a neurologist, I would be amiss if I didn't do a detailed neurological examination, especially when it comes to face pain. There's a lot of extra attention to the what we call the cranial nerves. And so these are the nerves that originate from the brain that largely control everything to do with the face. We do rely on a bunch of investigations that can be helpful. So lots of technology, including MRIs, CT scans, X-rays, EMGs, which are electrical tests of nerves and muscles. Of course, blood work, especially if we're considering systemic diseases. Lumbar punctures or spinal taps can be helpful because a lot of these nerves that exit the brain and the brain itself is bathed in the spinal fluid, and sometimes having a sample of that spinal fluid can be very helpful in trying to determine what is going on, especially for lots of inflammatory or some autoimmune disorders. But there is also overlap with other areas, so eye, teeth, and sinuses are also important structures to consider when we're looking at diagnostic testing. One of the aspects that I always reinforce with patients that a lot of our testings do look for what we call structural problems, so something that is altering someone's anatomy by the disease or disorder process. But a lot of these testing do not necessarily look for function problems where there's nothing wrong with the underlying anatomy, it's just the function of that anatomy has been altered for some reason. And a lot of these tests, again, echoing that, don't always show us some of these function abnormalities. When we try to think of an overall diagnostic approach, one approach can be sort of taking an anatomical aspect. So where is the pain, which structure seems to be primarily affected? And this can be one aspect, although over time what I've found is that a lot of these diseases and disorders that we deal with will have aspects of referred pain, and so the structure itself that's involved is not always the only thing to be considered. So, but again, you can think of all the different anatomical aspects that would go into this type of approach. Although more and more again, a lot of it would be focused on cranial nerves, but we also can't forget about sort of the upper neck aspect, because there's, from a network perspective in facial pain, there is actually a lot of overlap between the upper neck as well as the face and the head. Although over time we sort of have more evolved into sort of taking a disorder or a disease approach, and these types of approaches to a diagnosis tend to combine both the anatomy that's going on as well as the function of the individual bits, but also what we call the pathophysiology, or the underlying aspects of what we think is going wrong. And so this can be a very important approach. As a neurologist and headache and face pain expert, we look at sort of use the International Classification of Headache Disorders, which is now in its third edition. In the world of neurology and headache is used as a generic term to describe pain or discomfort in the head and in the face, as well as the upper neck. And a lot of these classification system is broken up into primary things and secondary things. But again, the big picture, as I was alluding to earlier, these diseases are sort of that tend to affect the structure or the anatomy of the bit, but also there's many diseases and disorders that affect the function of the individual components or the anatomy. I'm not going to go through all the different diagnoses, but a couple of slides here to list that there's a lot of different things that we're considering in terms of diagnoses into face pain, and some of these will overlap. But again, multiple things that we're concerned about. When it comes to some of the diagnostic challenges, one of the big things is time. That initial history and physical is a time-intensive process to get all of the details that go into coming up with an important diagnosis, as well as the treatment plan. And that's one of the things that I've always valued about Mayo Clinic's approach to care, is they do afford us that time to go through things. One of the other aspects that can be challenges when it comes to facial pain is there can be multiple overlapping specialists that's involved. So not only neurologists, but sometimes dentists, ophthalmologists, ear, nose, and throat experts. And so there can be lots of different specialties involved. And obviously it's great to have friends to help out, but sometimes things can get muddied in a way when there's multiple different specialists involved. And because of our sort of multidisciplinary approach that we use, it's super helpful in that effort because we are all communicating well amongst each other. Over time, a lot of diagnoses seem to have become very siloed. So one diagnosis cannot be conducive with another one, and that sometimes can add some diagnostic challenges, is because there are a lot of gray zones when it comes to these diagnoses, and patients don't always fit into a perfect silo. There's always these challenges about structure versus function problems, and there doesn't always have to be a structure problem in order for there to be a function problem present. And again, all of these things together, as I say, can start to muddy the waters and make things a bit more confusing. But what I found in practice, that nothing ever seems to be siloed. There's lots of things that tend to overlap. And ideally, we would have a nice simple Venn diagram like this ABC that we see, where it seems to be only 2 or 3 different considerations, and we can easily figure out where the overlap is. But what I've found over time is it tends to be more like the Venn diagram on the right-hand side, where there's multiple overlapping diagnoses and symptoms and things that are common amongst these different things. So again, trying to get to the main root of the problem, or that main diagnosis, can be somewhat challenging. But ultimately, at the end of the day, we do have to pick something to try to move forward, and it's okay to have sometimes 2 or 3 things on that list that we're working for. Sometimes it is very clear, and that can be very helpful, because then we have the collective experience of everyone that's come before with the same disease or disorder, and that can give us lots of good information in terms of treatment options. But if it is unclear, often we're left with picking the closest disease or disorder that it resembles, so that we can start down that sort of treatment path. We do usually pick treatments based on the diagnosis, but something that can be very helpful is finding those kernels of information from previous treatment experiences to potentially exploit or explore further in coming up to something that can be efficacious for the patients in front of us. Sometimes if we're unsure, if we have 2 or 3 things, sometimes there are treatments that have overlapping indications, and so we'll pick certain things that will sometimes potentially treat multiple different things, which can also be, again, helpful to try to find that efficacious thing for the patient in front of us. But really, when it comes to sort of the treatment landscape, we have lots of different things at our disposal, including medications and injections and neuromodulation and neurostimulation, surgery, radiation, and then of course a healthy lifestyle is also a key factor in treating patients with any type of pain, especially facial pain. And of course, the idea of living with and beyond pain is all part of the package. In a neurology or a headache, face pain specialty clinic, we're really focusing a lot on different medications, as well as some superficial injections, such as nerve blocks, and also some of the transcutaneous neuromodulation, neurostimulation devices. We have lots of different medications at our disposal. We're often stealing medications from other different indicated purposes. And it's not because the other indication is what we think is driving it. We're trying to exploit certain mechanisms of actions and medication that can be helpful in pain disorders, sometimes regardless of what their original intent was. And so this is just giving you the idea of the landscape that they're thinking about. And again, the benefits of having the multidisciplinary approach is that we have all of these other colleagues that you're going to hear from who are experts in their various areas. And again, it's such a delight to be able to work with a huge team of people, and sort of having that patient at the center as our goal to make better. And so next up, you're going to be hearing from Dr. DePel, one of our interventional neuroradiologists. We'll be talking about some more of these a little bit more invasive nerve block procedures that are usually outside our neurology clinic specifically. So I'll turn things over to him.
Good afternoon. Good afternoon, everyone. Thank you for inviting me to speak. As Dr. Green alluded to, there are many facets to taking care of facial pain and involves many different specialists. So I was hoping to use maybe the next 10 minutes or so to kind of explain what a radiologist does and maybe the component that we can contribute to your care. I perform percutaneous image-guided procedures. So that means, put a needle in somewhere or put a probe in somewhere. But as a radiologist, I use image guidance to get where I want to go. And so I'll go through a little bit of anatomy and then a little bit of kind of why we choose the processes and procedures that we choose. So let's start first with just a little bit of basic anatomy. And I think most people know this, but there are three branches to the trigeminal nerve, and hence that's why it's called trigeminal nerve. But we refer to them as V1, V2, V3, hence because it's actually the fifth cranial nerve, hence the Roman numeral 5. So from this point forward, I'll refer to them as V1, V2, V3, just to be concise. So the first branch, the ophthalmic branch, exits the skull and the cranium in the supraorbital fissure. Percutaneously, I can't get there safely. So the treatment, if that is involved, doesn't usually come to a radiologist. The other two, however, the mandibular, which is V3, and the maxillary, which is V2, I can get a needle to where they exit the cranium. And on this diagram here, I'd like to point out that the Gasserian ganglion, where the three branch, so that's the main branches, the ganglion itself, and from there you get three branches, is in Meckel's cave. It's a pouch intracranially where that ganglion sits, from which it has three openings that go out, as I said. So one thing I want to point out is that the maxillary, the V2 component, notice that it comes out horizontally, which means that the opening that it comes out of will be vertical, right? That would make sense. And then the mandibular division, which is V3, comes out downward, which means that the opening in your skull, which is, basically a round ball, will be horizontal. And that's important to a radiologist because we're using imaging to get needles there. And the trajectory that we use is based on where do we want to eventually end up. So remember this anatomy a little later when we talk about which procedure we're going to choose for what kind of patients. And the point being that the Gasserian ganglion is in Meckel's cave, and we can actually get there, but we may not always want to get there. Here's I'll give you some examples of how I see things. So this is a CAT scan, and generally I use a CT scanner for guidance. It's just a very accurate way of placing needles very precisely. Many places they will use X-ray, which is equally good. It's whatever the proceduralist is comfortable with. Just to get you oriented, the nose is upward on this image. It's as if we slice through you, horizontally, which is called axially. And this bone right here, bone is white, is the zygomatic arch. So if you were to feel the bottom of your eye and then go laterally, that's your zygoma. And normally we go just place a needle. This white line that you see here is actually my needle placement to get to a V2 block. This person, we were going for V2, which comes out of foramen rotundum. And on this axial image, it looks like a channel, but that circle is vertical when you look at it, if you are facing a person. And normally we go below the zygomatic arch, but sometimes we go above based on, a person's anatomy. Some people's cheekbones are higher than and some people's are lower. So that's all decided when we do a CAT scan. In this case, we can see that the needle is placed right where that V2 comes out. So out here, you're outside the cranium. In here, you're inside the cranium. So piercing the dura increases the risks of things like meningitis, hemorrhage, etc. So staying outside, if we can provide relief staying outside the cranium, that's ideal. That would be my first choice. On the second image here on the right, this white stuff that's new is contrast. And that's where we gave the medication for the V2 block that we did on this patient. And you can see how it just distributes right as the nerve comes out and bathes it. Here's another example. In this case, again, I am going below the zygomatic arch, and this is called the intercondylar notch. And I've got a 3D visualization on the right, and most people can probably identify that this is a skull and teeth, etc. And then you have the mandible, and this is called the intercondylar notch here. And that's a great place for us to just put a needle in laterally and get to wherever we need to go. In this case, we're trying to go to V3, foramen ovale. So we are right below the skull base, and we're going to inject right where V3 comes out. And remember, as I pointed out in that initial image, V3 comes out downward, so the hole that it comes out of is horizontal. And we place it right underneath that hole and inject right there. And in this example, this little dark line you see is actually the needle placement, which corresponds to this white line on the axial image. And so this is a V3 block for somebody who has the mandibular division symptoms. Here's another example of how we perform these procedures. This one coming in laterally, I place it in the pterygopalatine fossa, and in this slice, it's a little bit lower, so the foramen rotundum where V2 came out is a little higher. This is, again, another example of a V2 block, and you can see the contrast that's in the injectate, and it bathes the area where the nerve comes out. And again, I'm showing you all of these lateral approaches, and I'll talk about why that's a little different than one other point I'll make. This is one last example of a V3 block, just like I had shown you on the other side. This is right below the skull base, just getting into foramen ovale and getting into Meckel's cave. Foramen ovale is the exit out of Meckel's cave for V3. And here's another 3D example of this very needle right here, again, in the intercondylar notch. And this approach is excellent for staying outside the skull. But if we were to want to do ablations of the Gisserian ganglion or get into Meckel's cave, then you need to take a slightly different approach because we need to come upward. Because on this image, I would never be able to come higher, which is where Meckel's cave is because of the trajectory. And that's where we have a different kind of approach, an anterior transfacial approach. So this would be the intercondylar notch right here on the other examples that I had given. But in this case, we're coming through, here's the patient's nose and cheek. So you can see that we're coming anteriorly through the cheek. And what you can't appreciate on the single slice is that their head is quite tilted. So that I'm really coming in from down by the feet, going up towards the head so that we can actually get into Meckel's cave through foramen ovale. So these are just a few examples of what it looks like when I'm doing the procedure. For the patient, they're lying flat on a CT scanner on their back, and we usually use a little bit of moderate sedation if we're not going into Meckel's cave. And it's actually the patient's choice. It's not always necessary because the needle placement, these needles look very large, but they're actually quite fine. They're just long to get to the location we want to go to. So talking about the kinds of procedures we do, below the red line is not radiology, right? Radiosurgery is radiation oncology. Microvascular decompression, as Dr. Zimmerman showed, is a neurosurgical procedure. But other than the microvascular decompression, all these other things are in some way damaging the nerve, right? We're trying to hurt the Gisserian ganglion or the nerve peripherally in order to change how it behaves, change the dysfunction. We can do a nerve block with chemicals. We can do continuous radiofrequency ablation, pulse radiofrequency ablation, glycerol rhizotomy, and balloon compression. I'll go over just a few of these quickly without getting into too much detail. But again, the gist of it is that in all of these are things that a radiologist or an interventional radiologist can perform with image guidance, but they don't have to be performed by a radiologist. Neurosurgeons also perform some of these procedures. So in a balloon compression, you would put a catheter, which has a balloon at the end of it, in Meckel's cave and blow it up. Now you're compressing the nerve, so you're crushing the nerve. Okay. In a glycerol rhizotomy, you put a little needle up there and inject glycerol and alcohol, and that denatures proteins. And again, you're trying to somehow damage that nerve that is not functioning correctly. These other things are things that I'm more familiar with. Nerve blocks are just a chemical, we usually are peripheral. We don't do those in Meckel's cave, but continuous radiofrequency ablation and pulse radiofrequency ablation can be done there. These are differentiated by the temperature we reach. So just as an example, for continuous radiofrequency ablation, it's like a microwave set on high. You end up heating the tissues to anywhere between 66 to 86 degrees Celsius. You remember, water boils at 100 degrees Celsius, so that's fairly hot. So it would be basically scalding. So any tissue that's in that vicinity of that probe gets scalded and it gets kind of cooked, if you will. Pulse radiofrequency ablation, what it does, again, like a microwave set on a lower setting, is that it turns it on and off intermittently at varying degrees. And so what we're doing is reducing the amount of energy deposited in your tissues. And the probes are the same. It's just how much energy do we put into the probe. What that allows is a lower temperature, generally anywhere between 39 and 44 degrees Celsius. As the body is around 38 degrees Celsius, you're really talking about a very, very bad fever, if you will. So you're not destroying tissue. How it works, we're not exactly sure, but it is effective. And as far as which one of these to get, well, it's the one that your proceduralist is most comfortable with, because the side effects are a little bit different, complications are a little bit different, but efficacy is quite similar, except for pulse radiofrequency, which is lower than the others because it's not as destructive. On the other hand, because it's not as destructive, you can do it multiple times. So in general, I prefer to start with the least destructive treatment, which is nerve block. And then if you can want to go more aggressive, pulse frequency. And then finally, any destructive system that you want to use, whether it's radiosurgery, balloon compression, glycerol. Oops, sorry, I went backwards here. Or a continuous radiofrequency ablation. So again, where do we treat? I think about a couple more minutes. So where do we treat and how do I help make that decision? Let's say you have a patient that has both V2 and V3 symptoms, so maxillary and mandibular symptoms. Well, it would be good to treat Meckel's cave because that's where, right before they branch, and then you can treat both of them with one treatment session. And you can use whatever modality or technique you like, radiosurgery, balloon compression, glycerol, or radiofrequency ablation. But it's also Achilles heel, if you will, because what if you only have symptoms in V2? Well, now, if you're going to go into Meckel's cave and do a destructive procedure there, you can't exactly control where that glycerol goes, right? So it will affect both V1, or could affect, not let's say it will, but it could affect V1 and V3 as well. So you can get side effects that can affect the other nerves. So if you only had V2 symptoms, a better option, in my opinion, would be to maybe treat it out once it exits the cranium, to where we were doing the nerve root blocks. Of course, if we choose to do that, there's very little risk for intracranial injury, but then the procedures you can use are limited. For example, you can't do a glycerol injection because there's no container to hold the glycerol in. It will just diffuse away. So when we do it outside the cranium, right outside foramen rotundum, we usually use the radiofrequency, and that can be either pulsed or continuous, but it's very selective. So you have to choose the right patients. If you specifically have V2 symptoms, then you're a candidate for that. And as I said, you can't use balloon compression there because, well, there's nowhere to blow up a balloon. You can't use glycerol. So these are the kinds of things that we think about when we see a patient to decide, well, what's the next step? If, medication doesn't work, then what do we do next? And that at Mayo, we do as a team. And I would say, that's one of our advantages. And that's the last slide I have as far as content is concerned. But this last treatment option where you do radiofrequency ablation at foramen rotundum is a fairly new treatment. There are many places that do it, but it's not something like balloon compression, which has been going on for decades. The biggest advantage is very few side effects with that, particularly if you do pulsed RF. Unfortunately, the efficacy is not as good, but my personal philosophy is let's try the least invasive thing or the least aggressive thing and see if it works. If it works, hooray. If it doesn't, we can always do something more aggressive. In all of these procedures, the biggest risk from a percutaneous approach is bleeding, because we can't see blood vessels on the CT scan. If you hit a blood vessel, you can get facial bleeding. It's not life-threatening bleeding. It resolves. So that's the most, it's not common, but if it happens, that's the complication, if you will. The other complications, which I don't consider complications, are side effects, but they have to do, we know that going in, if it affects some other nerves, which could give you, weakness with chewing or possibly double vision, etc. That is all I have for content. At this point, I think I will introduce our next speaker, and I think we have a question and answer session at the end, so maybe we might wait until then for question and answer. So Dr. Parker, one of our neurosurgeons, is coming up next.
Thank you so much, Dr. Patel, for that introduction. Nice to meet everyone virtually. I see there's 148 people here online, so thanks for sharing a part of your weekend with us. And I want to say a special thank you to the Facial Pain Association for inviting us. And also thank you to Dr. Zimmerman, who's been a fearless and courageous thought leader in the facial pain space. He's not been afraid to challenge the status quo, to be innovative, to always push ourselves to come up with new treatment options and challenge how we've done things in the past. So that's been a great source of personal inspiration to me. So today I'm going to be speaking a little bit about facial pain and neuromodulation, a focus on the current options and what are the future innovations that are coming to this space. So I have no relevant financial disclosures, but I will discuss off-label uses of medical devices, and we'll return to this topic at the end. So why neuromodulation? When is it the right option? And in 12 minutes, it's hard to do justice to this topic. But generally speaking, this is not the first stage option. We have to understand where in the trigeminal system the pathology is occurring. Is this typical facial pain with a vessel loop? Is this atypical facial pain in multiple peripheral nerve root distributions? Is this anesthesia dolorosa or trigeminal deafferentation pain because of prior procedures or other injuries? So we have to understand where in the neuroanatomy the circuitry may be disrupted to understand where we should direct our neuromodulation. What we're starting to understand better, and no doubt all of you on the conference who deal with facial pain on a day-to-day basis understand that chronic facial pain reorganizes normal brain connections. It changes our mood, it changes our affect, changes how we interact with the world. There's been numerous studies who've looked at a structural element of change to the brain, both from structural elements of the hippocampus, memory structures, other areas of the frontal lobe, ways the brains activate, and fMRI studies that really show that chronic facial pain reorganizes this normal brain connection. So you can imagine physical compression is one element, but also how it's changing the neurochemistry of the brain is a secondary element. That's something we need to think about. The good news is there's hope. Some of these structural changes to the brain can improve with pain relief. This is a recent study actually just published in 2022 in the Journal of Pain, where they looked at some of these structural changes to the hippocampus in people, many of you with facial pain on the call, had actually changes in reversal of these structural changes when they attained pain relief. So there's hope that if we can move the needle, if we can improve symptoms, we can actually reverse some of these changes that happen in the brain. Where do we intervene? So I talked a little bit about earlier, where in this neural pathway, the trigeminal circuit from peripheral to the ganglion, to the brain, to the cortex, understanding the circuitry is important. And to be honest, we're still in the phase of better understanding that, and we're learning a lot through imaging studies. If neuromodulation is the right option for you, what device do we use? Does insurance cover it? How do we work to make it more available to patients? How do you program it? Who programs it? And who is a good candidate? These are all questions that we have to navigate on a day-to-day basis at the Mayo Clinic and at all centers that are doing this sort of cutting-edge neuromodulation for facial pain. So as Dr. Patel and other speakers, no doubt, across the conference have probably shown similar figures, but I just want to highlight again this idea of where in the neural circuitry matters. If we think this is a peripheral V1 restricted pain, something directed at the V1 distribution or supraorbital nerve may be appropriate. If this is in all three distributions, we may need to target the ganglion, for example, as we just heard from Dr. Patel's talk. If there's already been approaches that have tried to target these peripheral aspects of the trigeminal system, we talked about reorganization of the brain. Maybe we need to go to more central pain targets, such as the motor cortex, or even deep brain targets that affect the affect component of pain, or how pain makes us feel, such as the nucleus accumbens. So it's really not a cookie cutter model. It's really a very personalized, tailored approach. And oftentimes the patients I'm seeing to consider for neuromodulation has been through many other procedures before. So we have to be very, very methodical and very personalized in our approach. So it may be ironic as a neurosurgeon to mention the non-invasive options first, but if these things can be effective, they're always the best to try first. There's some very limited data out there for cutaneous stimulation. I'm not here to advise any particular devices from companies, but there's several people in this space. The good news here is that a lot of these devices have minimal risk or no risk at all. So if they can provide some degree of pain relief, these are oftentimes a reasonable thing to try, but oftentimes they don't provide long-lasting or durable pain relief. Motor cortex stimulation through transcranial magnetic stimulation, TMS, is a very, I think, intriguing option where there's beginning data that this can be safe and effective, and we'll talk a little bit more about this. Augmentation with brain navigation, better focal targeting of the TMS to the right brain region is probably important. Got to make sure it's the right area. If you're having right facial pain, we think that stimulating the left motor cortex is probably the most effective. TMS, questions that come to my mind anytime I'm thinking of a new technology, when new data emerges, first and foremost, is it safe and is it effective? For TMS, most patients can tolerate this fairly well. There are sometimes some discomfort and muscle twitching when we're dialing in the settings just right, and specialized practitioners who are trained in delivery of this therapy are able to do this in the most comfortable way possible. Where to target? I just mentioned the motor cortex has really emerged as probably one of the better targets, but there's also interest in the dorsolateral prefrontal cortex, deeper structures if we can get TMS there, such as the cingulate as well. But critical questions remain. How many treatments do you need? For how long? How can I continue this? Who's going to pay for it? All these things need to be sorted out. What it looks like is you can't get 1 or 2 sessions of TMS and have that be a treatment. These are just 2 recent studies that, from some of our colleagues across the world, some from France and elsewhere. They're really focused on doing an induction high-intensity phase up front for 3 weeks, and then 5 months of maintenance therapy that's less frequent. And as you can see in some of these line graphs on the right, where the pain relief is actually the pain score, is on the y-axis, and time is on the x-axis going to the right in weeks, you can see that it's not just the first week or the second week. It actually takes multiple weeks. This is out to 22 weeks to see the maximum effects of TMS. So it's something important if you can and you have the ability to get this treatment, to try to stay with it and see if it can provide you long-lasting effect. Invasive options. So as a neurosurgeon, we are trained in the art of navigating the cranium, both intracranially and extracranially, to try to target stimulation electrodes to areas of the brain where we know if we stimulate that area, we can change someone's perception of pain. One of the theoretical advantages of neuromodulation over destructive procedures is that neuromodulation allows us to titrate or adjust our stimulation settings. Again, getting back to this idea, there's not a one-size-fits-all approach. We have to personalize this for individuals. Neuromodulation approaches such as peripheral nerve stimulation, ganglion stimulation, allow us to do a trial period of stimulation by which we can see if this provides effect to the patient before we go on to that second stage of putting in a permanent system. Sort of a try it before you buy it approach allows us to understand, are you going to be a good patient who's going to respond to this? Is this going to be safe for you as a patient, which is always first and foremost in our mind. Deep brain stimulation, as we alluded to briefly, motor cortex stimulation, and actually combination approaches, both stimulating areas on the cortex and deep brain targets, have emerged as an area of inquiry and as an area of research. I think it's very promising. I don't think we're quite there yet, but the combination approach is probably what's going to move the needle going forward into the future. I alluded to peripheral nerve stimulation, and Dr. Patel gives a beautiful review of the anatomy, both of the extracranial and intracranial compartment, including where the ganglion sits and in the posterior part of foramina valley into Meckel's cave. So it can suffice it to say, depending on where the predominant amount of your facial pain is, we may need to target a peripheral nerve electrode in a specific area in this chain of the trigeminal system. If you have heavy facial pain in all distributions, we may need to get to the ganglion to try to stimulate across all these different regions. This is just a nice visual representation of this, and something as well that we can test when we do trial stimulation. This is just an example here. These things are done percutaneously for the most part, where we put in a lead underneath the skin, then we tunnel it underneath the scalp of the skull, and then generally speaking, put batteries usually in the flank or in the area underneath the collarbone. So these are devices that have electrodes and connectors. All these points are points of potential failure in the future. So technology and industry is really working together and partnering with us to make these devices safer and durable and less prone to failure. This is just a nice figure of some work done by Kunal Gupta, who's another neurosurgeon, who's described techniques to actually do this in multiple different areas in the trigeminal system at the same time. Supraorbital nerve coverage, infraorbital nerve, ganglionic stim. We may need to take a multimodality approach of not just getting one peripheral nerve distribution. We may need to have multiple targets. You can imagine as more electrodes go in, the implant becomes more complex, more points of physical and mechanical failure. So there's a lot of innovation to be done here in this space. but it can be a good strategy for the appropriately selected patient who's already gone through other less invasive options. This just highlights, again, in a nice visual format, some of the concepts that Dr. Patel was hitting on earlier, that where we get that electrode, where we get that treatment, if it's for a temporary block or actually for a permanently implanted electrode, mapping the, if you will, somatotopy or the spatial anatomic organization of the structure is very important, that we can deliver that in the right location. What frequency we do stimulate at, what amplitude, all these parameters are something that oftentimes get sorted out during that trial period, but can still take optimization once the final device is in. Briefly, motor cortex stimulation is another way to stimulate not the area directly of the trigeminal system, but in the motor and premotor cortex. It's been one of the more one of the neuromodulation techniques that we have the longest term study of. Dr. Kendall Lee at Mayo Clinic Rochester and his colleagues have been one of the thought leaders in this space and have employed this therapy with success over time. One of the challenges here, though, is the devices are all FDA off-label. There's still a lack of electrodes that are designed specifically to live on the brain surface. So oftentimes we have to use spinal cord stimulation type equipment to do this. So it can, again, be done in the right scenario, but there's a lot of room for technical advance here. Deep brain stimulation. And I really highlight here, the target is still unknown. What is the best target for severe facial pain, anesthesia dolorosa, refractory facial pain? I'd say by and large, our studies have been small with limited efficacy, but I think in the area of advanced imaging of the brain, functional imaging of the brain, white matter mapping or connectivity mapping of the brain, we're going to start to unravel in a patient-specific fashion which one of these cortical or subcortical targets may be best for deep brain stimulation. So I'd say stay tuned on this. This is something that the science needs to catch up on to make sure that we can predict with high accuracy which patients will respond to these targets in neuromodulation. So just in the last minute here, as I'll wrap things up, I think it's good to think to the future, and Dr. Zimmerman has certainly taught me that, to be innovative and to challenge the status quo. I'm very intrigued that some of these non-invasive forms, such as TMS, can be effective. But the challenge is it's just hard to get into the clinic every day. It's hard to do this therapy over the long term. There's colleagues at Rice University and other companies now that are trying to develop small TMS units that actually can be implanted through minimally invasive surgery into the skull. So you can get a therapy like TMS that doesn't have an electrode that penetrates the brain tissue, but just sits on top of the covering of the brain and may be able to have similar efficacy of TMS delivered externally. And that can be a challenge because it's hard to get into the clinic every day. So I'd say stay tuned. And I think there's a lot of reason for hope, and there's certainly a lot of innovation in this space. So disruption is important. It's come to cameras, it's come to our navigation, encyclopedia, all these examples here, how we hail a cab. But we need these things to happen in facial pain. What are the areas that I see of greatest need from a patient perspective and the patients that I talk to is that we really need a way to predict for individuals which one of these options is based. I'm hopeful it's going to be imaging. For those peripheral neuromodulation candidates, I think we really need to have better devices specifically designed for the trigeminal system, specifically designed for the ganglion, specifically designed for those extracranial branches of the trigeminal nerve. We don't have those devices yet, and we need to work with industry and find innovative ways to fund doing that sort of research. And lastly, let's keep our eye to the future. And I think a lot of these minimally invasive devices, ways that we can do TMS or transcranial magnetic stimulation in the skull, I think this may allow us to move out of the brain. That may sound ironic to hear that from a neurosurgeon, but I think that's the direction that we need to head. And I think that's how we can deliver the safest and most effective treatments for our patients. So with that, I'd like to hand things off to my next colleague to talk about the Pain Rehabilitation Center. So thank you so much for your time today.
Hello, my name is Cynthia Townsend. I'm a clinical director for the Pain Rehabilitation Center at Mayo Clinic in Phoenix. And I will just introduce myself to say that I've been working with people with chronic pain for about 24 years. And I feel myself very grateful that I get to do this work. About 21 of those years has been at Mayo Clinic in Rochester, and the last 8 years in Mayo Clinic in Phoenix. When I first got into this work, my supervisor told me, be sure you have a good self-esteem because no one's going to want to see you. And what he meant by that is people are not supposed to come to the point where their chronic pain has not been cured. It's not supposed to happen. And yet, when all of my colleagues, whom I share a lot of patients with, my colleagues who you just met with, what happens when either the procedures don't work, the pain may be worse, procedures were they were maybe not candidates for them, or the surgeries. That's usually how individuals are referred to a pain rehabilitation approach. And so I'm holding that grief at the same time that I'm trying to loan that hope of how can someone's life be in better functioning and quality of life, even if we can't cure their chronic pain. So in this context, the pain, whether it was initially related to an injury or a disease process, and that has been healed, but the pain persists, or maybe the pain was spontaneous and there's no specific cause and what we call the dreaded within normal limits. Sorry, we can't find anything, and the devastation and the demoralization that comes with that experience. That's usually the focus that we take from a pain rehabilitation approach. And it's not just about the pain, as we all know, on the 0 to 10 scale. I was asked to be a consultant on the Arizona DHS medical school curriculum, which we do use at Mayo, and doing the teaching. And one of the areas I was asked to present on was the impact on the family. And that was because they knew that I did that work as well. And one of the things that was interesting is this was unfortunately the easiest literature search that I've ever done. Impact of pain on caregivers of cancer, impact of on family members of those with loved ones with cancer is a huge body of research, and takes a lot to get through. But the one on chronic pain is actually so small. It took a really short, probably half hour to get through. And as we take a look at some of the results of some interviews talking about it, it's not just the pain, it's the impact, the roles, the burdens, the emotional impact, and the uncertainty for something that was not supposed to happen this way. My one of my favorite quotes, I've been using it for over 20 years, is because I think it gets at the crux of what we have to kind of take a step back in big picture. And my colleague, Dr. Parker, alluded to this as well. Distress, disuse, and disability are all important facets of a chronic pain problem and all require clinical attention. Neglecting one of these components can produce treatment failure, even in the presence of excellent care for the others. And the reason this is important is because at times I'll work with individuals and they're not quite sure how an integrated or interdisciplinary approach can be helpful because they've already done the PT, they've already done the psychology, they've already done the OT, they've already done relaxation. And our focus is taking a step back from that and blending all of these ingredients together. And just like you can have eggs, flour, cocoa, oil, and it's not until you blend them together to get a cake that you get a completely different product. And that's important to make sure that all of these areas are being addressed simultaneously. The reason this is important is because the problem itself turns out to be quite complex. This is one of my favorite manuscripts that came out in 2018 out of the University of Kansas Medical Center. And after like, almost a couple decades of working with individuals with chronic pain, I finally had a better understanding and feel like I have a more understanding of why chronic pain may happen, the mechanism behind centralized pain, central sensitization, than I did in the first 2/3 of my career. So our understanding in this complexity, the old model was, well, if we can't find the disease or the injury or the lesion, then the pain that still continued must be part of a psychiatric condition. Maybe it's part of wanting attention. Maybe it's part of a diagnosis of hypochondriasis or hypochondriac or wanting medications. And the stigma and the demoralization that goes with those stigmas is so huge and so defeating. And being able to understand for the first time a different picture of this, the understanding here that I wanted to represent and let me nerd out for a moment is what we understand is across a person's lifetime, if they have what we call hits to what is the stress response system, HPA axis, your hypothalamus, pituitary, adrenal response is the stress response. And stress is not just psychological, it is surgical, it is infectious diseases, it is traumas and hits to your body and your mental well-being. If a person has a lot of hits to them to this system in their lifetime, then we see a cascade of events changing in order for your entire endocrine nervous system and immune system working together to help protect you. So that threat response means then all of a sudden it's like putting a wedge under the door to keep the door open. We're going to keep the door open because you keep going through it. We're going to let the signals become more efficient and louder. And unfortunately, that's not what we wanted to happen. And so then pain that shouldn't make sense, touching, light breezes, there's no tissue damage, yet it feels so intense. Smells, light, sounds, radio wavelengths of light shouldn't be painful, but they are. What we see in this shift in is then a system where 1 + 1 = 8, and the system doesn't turn off. And that's what this picture is representing in the context of including facial pain, which is considered a central sensitization syndrome as well in this context. I work in one of the 3 Mayo Clinic Pain Rehabilitation Center programs. My colleagues that started the program, it's not a new concept. It was in 1974. They said, we can't do this work alone. We need to have all of our colleagues working together simultaneously on the same person, talking in real time with one another, being able to raise concerns and celebrations as we focus on how can we work on the goal of re-regulating this HPA axis. That's what we were doing when we didn't know what we were doing in the context of central sensitized pain, since we didn't have those words. Within this concept, so I do it in what I consider the 5-course meal, where we're teaching 100 hours of cognitive behavior therapy, biofeedback assisted relaxation, how to engage exercise in a way that can improve your tolerance for movement, just not on the side of pain, but your overall stamina, endurance, everything that's going to impact that nervous system. How we talk about physical reconditioning, Tai Chi, being able to help decrease the cortisol, running on the same system and approach, managing flares. You can do this in a one-to-one kind of scenario where you're working with a therapist, a cognitive behavioral therapist, a physical therapist, perhaps an occupational therapist, doing relaxation training. We happen to do it in a 3-week intensive program, so that way it's more like I would consider it more like a language, where you go to the country and it's a language immersion where you learn the language as you're practicing it, with the feedback given real time. Um, the part that I'm proud about in that concept is when my patients come to us and when they're asked at the end of this, how could this help with my pain? How could this, I'm so nervous and skeptical. And I'll tell them, be nervous, be skeptical, but be willing to get an honest answer on how any of these concepts can work together. So I know they're coming to me at a -15. When they work their way up to a 4.9 out of a 5, saying this is helpful for me, that I would recommend it to my family members or individuals with chronic pain that I care about, is a pretty important technique for us to consider. I wanted to put a resource in there. This is a 20-minute video that I can't play today, but I want to reference to you. You can go to YouTube and find it. One of my clinical director, my colleague, my former mentor, when I was a fellow, Dr. Slutton, he uses the central sensitization syndrome video that you can access to help explain how central sensitization is something important, not just for face pain, but for all types of pain as well. Most of our patients usually feel that they have, every time they go to the doctor, they have a new diagnosis, because 80% of them have more than one side of pain at this point. And I wanted to give an introduction to if there's more information that we can provide on pain rehabilitation center approach. I have a short amount of time, 10 minutes, to talk about something I can easily talk about for 3 hours. And I'm an extrovert, so with a little bit of provoking, I could probably go for 4 hours. One part, I'm going to go back because I didn't mention this. This is an important part. Why did this happen? Hits to the nervous system. The potential understanding is genetics. And don't just focus on genetics of family members who have the same side of pain. The pain might be presenting elsewhere. 2, pediatric pain. If you had pediatric pain at a young age in the formation of the nervous system, particularly, we find that our young people are at disadvantage of their pain not being treated as seriously and as aggressively. 20 to 30% of them that have acute pain will develop chronic pain. Physical hits, motor vehicle accidents, concussions, infections, surgeries, even uncomplicated ones, those are all hits to that same nervous system. Psychological hits, I know this was referenced earlier in the trauma talk, but it doesn't have to be just a single trauma event. It can be a traumatic life. So if you've ever had to survive your life in any capacity, whether there was untreated mental illness, untreated substance abuse, where you have to scan friend or foe, what is the sound? What is someone's voice? What is going to happen to me? Do I need to save myself or someone else? Some of my veterans, when I worked at the Minneapolis VA, who were not in combat direct, but they were in combat readiness areas, again, sleeping with one eye open, the level of vigilance that that same nervous system, endocrine system, and immune system has to function to kind of help right the level of stress and the impact. Individuals who were lived in poverty, violence, caregivers who have to scan every breath and sound and heartbeat, whether professionally or also within their personal worlds, the caregivers to others, including pets. My individuals who have risk for burnout. So 95% of the individuals I work with are high achievement striving perfectionists, self-identified, so they can take this amount of resources and make this happen, but often at the cost of themselves. So again, that surges on the same nervous system that we're talking about. And if any of those happen where an infection hits surgery, impact that is part of a subacute acute pain happens at the same time of other stressors, losses, grief, bankruptcy, divorces. All of those pieces are all being held on the same system, which is again why when these circumstances, when we can't end this chronic pain, unfortunately, with the grief of that, we work towards how can we control the aspects of this and change to do the work to re-regulate the HP axis for the long game. This is not a short kind of unimodal 3 weeks. This is something, how can we create a life that's more sustainable from a well-being standpoint? Thank you.
Thank you, doctors. Really wonderful information about how to take a multidisciplinary approach, how to really get the full spectrum of the challenges that living with facial pain face.